Hey everyone, I'm back again with another lesson. This is about retropharyngeal and the lateral pharyngeal abscess. The retropharyngeal and the lateral pharyngeal lymph nodes that drain the mucosal surface of the upper airway and the digestive tracts are located in the neck within the retropharyngeal space. As you see on the image, retropharyngeal space is located between the pharynx and the cervical vertebrae and extending down into the superior mediastinum. So, retropharyngeal space infections are at risk of progressing to dissemination to the mediastinum. And the lateral pharyngeal space is bounded by the pharynx medially, carotid sheath posteriorly, and the muscles of styloid process laterally. The lymph nodes in this deep neck space communicate with each other, allowing bacteria from either cellulites or node abscess to spread to other nodes. Infection of the nodes usually occurs as a result of extension from a localized infection of the oropharynx, and retropharyngeal abscess occurs most commonly in children younger than 3 to 4 years of age. This is because after 5 years of age, the retropharyngeal nodes involved. Males are affected more often than females, and approximately 2/3 of patients have history of recent ear, nose, or throat infection. Etiologically, retropharyngeal and the lateral pharyngeal infections are most often polymicrobial. The usual pathogens include group A streptococcus, oropharyngeal anaerobic bacteria, and Staph aureus. Other pathogens can include H. influenza, Klebsiella, Mycobacterium avium intracellulare. Regarding clinical manifestation, the clinical manifestation of retropharyngeal abscess are non-specific and includes fever, irritability, decreased oral intake, and drooling. The verbal child might complain of sore throat and neck pain and also neck stiffness, torticollis, and the refusal to move the neck might also present. Other signs can include muffled voice, stridor, respiratory distress, and even obstructive sleep apnea can happen. Physical examination can reveal bulging of the posterior pharyngeal wall in 50% of infants. Cervical lymphadenopathy may also be present in the case of retropharyngeal abscess. Lateral pharyngeal abscess commonly presents as fever, dysphagia, and a prominent bulge of the lateral pharyngeal wall, sometimes with medial displacement of the tonsils. Differential diagnosis includes acute epiglottitis and foreign body aspiration in children. In the young child with limited neck mobility, meningitis must also be considered. Other possibilities include lymphoma, hematoma, and also vertebral osteomyelitis. Once we suspect retropharyngeal abscess clinically, soft tissue neck films taken during inspiration with neck extended might show increased width or air fluid level in the retropharyngeal space. And CT with contrast medium enhancement can reveal central lucency, ring enhancement, or scalloping of the walls of the lymph nodes. Treatment options include intravenous antibiotics with or without surgical drainage, a third-generation cephalosporin combined with ampicillin sulbactam or clindamycin to provide anaerobic coverage is effective. More than 50% of children with retropharyngeal or lateral pharyngeal abscess are identified by CT can be successfully treated without surgical drainage. The older the child, the more likely it is that antimicrobial treatment alone will be successful. Drainage is necessary in the patients with respiratory distress or failure to improve with intravenous antibiotic treatment. Complications of retropharyngeal or lateral pharyngeal abscess include significant upper airway obstruction, rupture leading to aspiration pneumonia, extension to the mediastinum, especially in the case of retropharyngeal abscess, and thrombophlebitis of internal jugular vein and erosion of the carotid arteries, which can occur. This is all about retropharyngeal and the lateral pharyngeal abscess. Thank you for watching.